just want to share some concept about approach selection in cranial neurosurgery. This is an overview. This is the microneurosurgery era, and Professor Yashagi taught to all of us how to expose the lesion, how to navigate the system, and how to, perform what we really define minimal invasive surgery. Minimal invasive surgery lies in the respectful of the anatomy, not in the size of incision, of craniotomy, or everything. And in the cases that we just saw, we saw as to go there, exploiting and taking advantage to navigate each sulcus and to go deeper and deeper inside the brain, even in the most difficult and deep-seated part to deal with. And this is an overview of what we do every day in our OR. We take advantage to exploit some natural corridors to go there, interhemispheric, sylvian, basal circin, and everything, working around a common target that we have to keep in mind to reach the lesion. The same concept is in skull-based surgery. Skull-based surgery is exactly the same. In skull-based surgery, we remove the bone and leave the brain alone. Why? Because we don't want to retract the brain. Why? Because the brain is super delicate, and the dangerous that we can do to the brain, it's sometimes more aggressive and irreversible compared to the initial pathology. And this in this seminal pivotal article by Professor Spezia that require no presentations, he talked about the quiet revolution of retractorless surgery. And we do everything to try to avoid any kind of retraction in brain surgery, in the skull-based surgery. And to do this, we use some specific approach that are time-consuming, long-consuming, and everything. And our goal is just one. In every kind of approach, the approach selection. Our goal is try to avoid any retraction of the neurovascular system, because the best retraction in neurosurgery is no retraction, as we know very well. So now some beautiful consideration about the orbit here. And we see that in the orbit, how beautiful is this anatomy in terms of representation of neurovascular structure, muscle, nerves, especially the optic nerve, and especially the central retinal artery and the ophthalmic artery. And these are a long series of the complications that comes from the eyeball compression. You see, we can have some ocular complication, orbital, periocular, functional, iatrogenic settings, and everything. And since when I was resident, everybody taught me that I should be compulsive in protecting the eyeball during non-ocular surgery, during neurosurgery, and we have some anesthesiological recommendation to avoid any kind of eyeball compression during non-ocular surgery, eye protection and positioning and everything. And we have even some guidelines coming from anesthesiological colleagues about eye protection in anesthesia and intensive care that are very important to follow if we want to avoid some tremendous complication here, and we have some preventive action, rational timing, and everything. And we start to use this kind of technique during our ORs in, extraocular surgery, just to protect the eyeball, to protect, the cornea, to protect everything. Even in paraclinoid aneurysm, we live in the era where we talked a lot about the preservation of the ophthalmic artery here. And why? Because the preservation of the ophthalmic artery is critical to avoid blindness here and to avoid the risk of ophthalmic artery occlusion. And this is one of the reasons why today we use most of the pipeline device to treat most of these, aneurysms about paraclinoid region and everything. And one of the most fearable complications is the central retinal artery occlusion. This is a case of central retinal artery occlusion here. And this is a terrible complication because the patient can be blind. Despite from all of this, today we are talking a lot about transorbital neuroendoscopic surgery, and the idea that sometimes, we listen to is that we can retract the ball, we can transgress and trespass the orbit to go inside the brain and to remove almost every kind of the tumor inside the brain, at the level of the anterior fossa, middle fossa, cavernous sinus, retrofossa, even clipping aneurysm and even removing the tumor. Also in this case, for example, this is one, transorbital approach for cavernous sinus meningioma, where we see into the orbit 3 surgeons, 6 hands, and 4 instruments inside the orbit, despite the fact that everybody taught to all of us the best way to protect the orbit during surgery. And this is, the chapter from some masters of this kind of technique about the complication. And we see here some complication about what they call Tonnes approach, and they tell that this is the real game changer in skull-based surgery. But this is a long list of complications, and this is a variation. This is trans-eyelid supraorbital endoscope-assisted approach, and this is the patient a few days after surgery. Just to clarify, I'm not against this kind of approach. I was, among the first to, popularize this approach in treating orbital lesion, but this is very good approach in my humble opinion for orbital lesion, not intracranial lesion, because in intracranial lesion it's not a good idea going through the orbit to go intracranial for the reason that I just showed you. And this is, just some of my cases. This is anterior skull base basal forebrain lesion. We have 2 different kinds of lesion, and the left one is a huge glioma here. And this is one of the last patients that I did, 1 month ago. And he came to my office yesterday. This picture was done yesterday at 20 days post-operative day. And this is the scar of the patient. This is the scar, the skin incision of the patient, and 28th day post-operative day. So this is for me minimal invasive surgery in terms of especially aesthetic outcome. The same for terminal approach. I don't want to take too much time here. But this is what I want in terms of approach-related outcome from, what they call, this is for me, my humble concept of minimal invasive surgery. These are 3 different patients. The first one, anterior clinoid meningioma, low-grade insular glioma, and MCA aneurysm. And in all 3 kinds of surgery of patient, it's difficult to find where the skin incision was. And the outcome of this patient was perfect, because I want to say once again, and I want to stress once again, especially for young neurosurgeons, that, the best retraction in neurosurgery is no retraction, and the minimal invasive lies not in the sites of craniotomy of the skin incision. The minimal invasiveness of any approach lies perfectly in the full respectiveness of the anatomy. And this is a sentence from Isaac Newton. It was, his reasoning shaping the foundation of modern knowledge. And Isaac Newton shocked us with this very simple concept, according to which wrong assumptions lead to wrong conclusion. So we have some wrong assumption about approach selection in cranial neurosurgery. Less approach means less invasiveness, less distance, less bone opening, less exposure, less skin incision. Less size means less blood loss, less operative time once again. But in neurosurgery, one of the most important aspects coming from one of my mentor, Professor Almefti, is that less is less. I don't have, unfortunately, time to show my cases. I want to stop here, and I'm here for any kind of questions or whatever you want. Thank you so much once again.
Thank you so much. I think in the interest of time, we'll move on to the next session, but thank you for concluding on a very nice ending message. On to my colleague.
Thank you.